live, Grant.
I quite like the placeholder. But do we not get to see anyone else?
No, I think it's a one-way system, so I don't actually have any idea if anyone's here. Is anyone here?
This is hilarious.
Joe's here. Doesn't give us like a view count or anything, does it? No. Mark might know. Find out.
Mark says, "Off you go."
There you go. Spoken.
Okay, excellent. So, welcome today to this session of Let's Do Digital on Ask a GP or a clinician everything they want you want to know about their experience of digital. We are aware that the platform is not so good at asking questions. So those that can comment, please do. And we will get to those comments, questions, queries at the end. I'm Grant Valance. I'm part of the Let's Do Digital team. In my day job, I work as an information manager in the Oxford University Hospitals Foundation NHS Trust in the Department of Clinical Haematology. And Dom and Anita today, who are speaking to us today, will introduce themselves. So without further ado, I shall hand it over to you, Dom and Anita.
Thanks. Okay, great. Hello, everyone.
Hello, everyone. Excellent. So, this is episode 4 in the Ask a Clinician series, but actually you're asking 2 GPs today, so 2 for the price of 1. And just kind of give you a bit of an overview, what we'll cover. We'll do some self-introductions, talk a bit more about what we do, why we got into digital health, show you some of the problems that we face, and hopefully open up some sort of discussion towards the end about what we can do to improve things and make it better for everyone, including our patients.
Great.
Do I click or do you click? No worries. So my name's Anita. I'm a portfolio GP and I have a lot of interests. My main 2 roles at the moment is that I'm a medical monitor at Lindus Health. So this is a health tech biotech startup. They're a clinical research organization, and I essentially work in clinical trials, making sure that participants are safe on clinical trials. In my other role, with more of a digital health hat on, I'm the Southeast London ICB Digital Transformation Clinical Lead. And whilst it's a bit of a mouthful, essentially what that means is I kind of look into digital solutions, see how they can be implemented or improved in primary care, the interface with things like community pharmacy, adult health and social care. And I know Dom because he works at Health Tech One, and that's one of the products that we do use in Southeast London.
Yeah, thanks, Anita. Actually, I got this job because of Anita, so this is all very, and so I'm a GP on Thursdays these days. So I do 1 day of clinical work a week, which keeps me really close to the problems, and it's really nice to spend that time with patients and doing that work. But I spend the rest of the time at Health Tech One because I was very frustrated by the tools that we use in medicine, how they often work against us rather than with us to get our work done. Right from the first day in hospital when I was in training, I remember just being astonished by the kind of the tools that we have to use and how the software is not only just very ugly and like unpleasant to use, it's kind of ergonomically unpleasant, but it's hard to configure or doesn't configure. It's dangerously difficult to use, and gets in the way of doing simple work that you need to do in your day to day. And so I joined Health Tech One about 1.5 years ago now, when there were just 6 of us. We're about 28 now. And we automate tasks for admin tasks in primary care. And rather than kind of giving practices another tool to use, we try to kind of add value straight away through automation, which is really fun. I'm really enjoying that role, but it's good to still be doing a little bit of clinical work as well. Right, I'm going to hand back over to Anita to talk about.
So this slide was meant to be interactive, but then we realized that there wasn't really an interactive function on this platform. And this kind of goes to show essentially what we face in GP as well. There's so many forms of software. Which one do I choose? Here in terms of meetings, you've got Teams, Google Meets. What else do we have? I don't know. I don't know. I don't want to use any more. But then we've got this as well for meetings. And this is like a whole new ball game for me. I'm like, oh, what are the functionalities? How do I log in? And actually, in order to be able to comment, for example, you've got to have a YouTube account and then get verified through it. And that's very similar to what happens in GP. You use what you have to do. There's just a minefield, and you just have to find your feet. You play along with it. And actually you realize there are other problems, even though that's the best solution that they've given to you. So one of the problems that Dom and I face is integration with secondary care, the electronic health records. There's more and more admin that we get, and this is affected us in different forms, either emails or AccuRx messages. So we spend a lot of our time really firefighting. And when patients come and sit in my consultation, they say, "Can you not see it on my records?" I'm like, where do I start? Where do I go into? We're getting more patients, more tests, more referrals. And it's a lot of the time in my consultations, I find that I'm pretty much firefighting and being as efficient and navigating all the softwares that I have as best as I can. And I can't demonstrate this, or I can't complain to my patient. I just do. And actually, there is a lot of burden on us. And if there are any mistakes, we can't go around and say, "Oh, it's because I was pressed for time," or "it's because of the software." It really boils down to us and our responsibility. And so one of the reasons why I got into digital was to try and improve this, or find a way to improve the system and the processes that are involved in my role.
Fantastic. Yeah. And I think Anita said already, but this is on a background of just everything is increasing all the time. We said it there with more. But, every year, more and more patients register. You're asked to do more and more at the same time. And we're often patients make jokes about us being, doctors for the computer, not doctors for them, because we say hello to them and then we turn to the computer. And I try very, very hard not to do this, but it's impossible, because they start talking and they mention, "Oh, I had this scan," or "I went to see this clinic." And the first thing you do is you think, "Okay, I need to see that report. I need to see that letter." And so you start pulling it up. You're still listening to the patient, but, that experience for them is immediately less good, because
I think so. And I think there's a lot that digital can do, but we need to keep that human element. And I think some patients do just want to have that human to human interaction, and actually to face someone with their full attention, as opposed to someone typing away. I find that quite irritating if someone's typing in the background. I know they're not really, are they really listening though? And that's the question that I ask. And I think because that's how I feel, I use pen and paper so they can't hear me taking notes.
Yeah, we
and
sort of
so
already.
Yeah, go on.
Yeah. I was just saying we sort of moved on to talk about this already, but go on, Anita.
Yeah. So, and why did we want to get into digital health? Well, we're both GPs. We're doing the working the job. The pain is really real, and we're both quite problem-solving minded individuals, and we like to fix things. Dom's more kind of technical, so you can talk a bit more about your technical experience, and we just want to find a way to make things better. I don't program, I don't code. I tried. Mark Bailey, who's hosting these series, did try to coach me and mentor me a little bit, just couldn't pick it up. And I don't have the time. It is literally a full-time vocation to learn to code. And so I pivoted into digital health, looking more at like management and leadership roles, looking at systems processes, how and just to take it back to basics, like how are software procured, like how are they, assessed for clinical safety, for example. And my aspiration is to really improve and change digital in a positive way. I'm sure everyone wants to do a bit of that, but I'm very restless, and I was like, I must get involved. So, for example, kind of just to go off on a tangent, recently someone kind of asked me to join a workshop or a focus group about first contact maternity care. And I'm like, yes, I want to get involved. I've got opinions, and I'm happy to give those opinions to you for free so that we can do something to improve it. And that's been quite a really interesting and fruitful conversation. So yeah, if you guys have any pain points and you want a GP perspective, happy to give it to you, and also maybe show you what it's like on our end. Because we do try, but we're just kind of at breaking point with all the things that we have. But I'm happy to take the time out and just to kind of show you and answer any questions that might help with your projects and things.
Yeah, I think probably there's no substitute for spending a bit of time in general practice if you're able to. We're not sure exactly the makeup of the audience listening. So, but if you haven't had the opportunity to actually spend time in general practice, if you can find a way to do that, I think Mark does try and facilitate that kind of thing as well. That's probably one of the most valuable things you can do. But yeah, I don't want to talk too much about myself, but just briefly, I mentioned Health Tech One already and what we do. And I was sort of doing a little bit of hacking around on my own EMIS computer and used this amazing tool called AutoHotkey to basically script a bunch of actions in EMIS, so I could save myself a few hundred keystrokes a day and a couple of minutes here and there. It's a brilliant little tool if you've never used it. It just runs in the background in Windows. You don't write these very easy little scripts to drive a UI. And so I could do things like, Control R to bring up a referral box and that kind of thing in EMIS. And that just gave me a little bit of power back over this horrible system that I had to use. And every time I use it, I just feel a little bit smug. But also it does speed me up a bit, which is quite nice. But yeah, what Anita said about wanting to kind of do something straight away is also drives me. I think the NHS is a wonderful thing, but it moves very slowly, and often these conversations about procuring new tools or kind of working with industry to develop kind of new solutions to problems move very, very slowly. So that's sort of why I've slightly gone to the dark side to work in a startup. But yeah, we're all fighting in the same direction, I think. Cool. So should we talk a bit about the electronic health records and stuff, Anita? Should we?
Yeah, I think that would be a good start.
Okay, cool. All right, ready, steady.
Yeah, so this is clearly a very, very busy slide. And really, the reason why we've just put it all on one slide is to kind of demonstrate the roles, what we're supposed to do with electronic health records and how overwhelming it can be. Not only are GPs involved in maintaining patient records, making sure it's all up to date, the alerts are there. We have to manage demographic information as well. Ethnicities that pop up just comes in the corner of EMIS. And what am I supposed to do with that? I'm already strained for time, but I have to action those things really for holistic, complete patient care. There's other things, if medication reviews are due and blood tests are due, I have to action that. And there's just not enough time in the consultation to do that. So we're getting lots of pop-ups, we're getting lots of reminders to review medications, to do the monitoring blood tests, and then referrals as well. If our referrals get bounced, we also get a notification to say your referrals bounced, sometimes not even why it was bounced. So you have to kind of spend the time, and it's not scheduled in your day-to-day. You have to go through it and look at it and see why it may be rejected, for example. And sometimes it might not even be that it's rejected. It's that labeled as rejected, but actually they've been booked outside the ERS service. And Dom's nodding because he knows what I mean. But unless you kind of experience it yourself, you really don't know the potential frustrations that we face. And then besides that, there's appointment scheduling, task management. So task management is things that other people might task you. Oh, Anita, can you review this referral, or can you review this clinic letter? Or you might even end up tasking yourself to set yourself reminders, because how do you keep track of all these things that are going on? If there's a patient that I'm a bit concerned about and I've referred them down the 2-week wait, which is the cancer pathway, and I'd like to follow up on that. Often you do the referral and it goes into the ether and there's a follow-up template. But if I'm really curious about them and I'm really concerned, I tend to set myself a task to kind of follow up them by myself manually, also to know what their outcomes are. Or if I'm concerned about their mental health, etc., I check in, and that I do in my own time. In terms of more governance stuff and population management, there's QOF that everyone hears about all the time, and how GPs are trying to, make sure they're on top of QOF, etc. And that, this electronic health record is supposed to encompass all of these things, as well as other things as well. And then lots of other softwares are integrated into it with APIs and things like that. And it just becomes just like an absolute minefield. And it does take time to get used to it. I think, if I'm honest, in GP, I just use things on an essential basis, but actually all these other softwares and EMIS itself, which is the electronic health record that I use, it has so much more potential, but I just don't have the time to do a deep dive and actually understand, how can I use this more efficiently? How can I set up my shortcuts? And if anyone who's out there who's a GP that have really good shortcuts, please do share them with us, because I would happily take them on and maybe even pay it forward and share it with other people if you're down for a bit of collaboration.
I don't think you've got mine, have you? So I'll sort that out. But yeah, I mean, I guess the point of this kind of busy slide, I think that's a really good summary, Anita, but is that the GP EHR EMIS and System 1, we'll talk a bit about specifics in a minute, have to do so many different things at once. And as a GP, you have to do a million different things at once. But also in the practice, there are a bunch of other people, nurses obviously as well, but admin staff doing a million other things with the same system. And so it does all of these things, but it does all of them sort of okay, and doesn't do any one of them that well, which is where it's kind of quite challenging for us to use. I don't know whether everyone definitely knows what QoF is, but assuming you do, essentially it means that you have to be able to collect reliably coded information out of the patient's records across your whole patient population, and then produce reports on how well you're doing on certain targets, whether 50% of your patients are reaching their cholesterol lowering targets for the year or that kind of thing. And it directly relates to how much the GPs are paid each year. So there's a sort of financial incentive to get all this work done, to actually help improve the health of your patients and do that work. But it's also, a lot of the work is admin, and it's not, practices have whole teams devoted to gathering the administrative or doing all the kind of administrative work to get that coding onto the system to make sure that it's there and that they'll therefore get paid for having done so. But it's literally a full-time job for several people in every practice everywhere in the country. Cool. Let's move on. This is a very busy slide, but just to give you a bit of an idea that the medical record has, again, this is on the electronic record, has to contain a huge amount of different bits of content, and that all those bits of content can be in different formats, which again kind of illustrates how difficult it is to digitize things, even when we're now kind of a long time into using electronic health records rather than paper health records primarily. We still find that letters and things can arrive in the clinical system as screenshots or as photographs, which are then uploaded. Actual photos or videos of like photos of a skin lesion, for example, it's reasonable for that to be a photo, but often it's a report that's been photographed, and you can read that, but you can't copy and paste it, and you can't use that text elsewhere, and it can't be interpreted by the computer in any useful way. And the consultation record itself, has to have a lot of kind of bits of information, which if you can write in a sort of in freehand, it's easy to store if you just store a big block of text. But if you want that information to be usable by other systems, it has to be coded using the coding word, the ambiguous coding word, but coded as in clinically coded with SNOMED codes or whatever the equivalent is. And so yeah, it's a complicated thing to try and integrate with. I also want to talk a bit about how data is, who owns the data in general practice versus kind of other areas of the NHS. And it's a bit strange, and I didn't really realize this until quite recently, that the GPs are the data controllers for their patients' medical records, and so they actually, in a sense, own the data and are responsible for what happens to it. And that's okay, except that when we're being asked to open that data up a lot to other systems, which is a really good thing because we want to integrate with secondary care. We want them to be able to see our patients' records when they need to, if a patient turns up in A&E, and we want to see their data as well, of course. And record sharing is really vital. If an ambulance goes to someone's house, it's really good that in my area anyway, they can bring up the GP record, and I think they can't read consultations, but they can see a medication history and a problem list, as long as those things have been correctly coded, which is not a given. And that's very, very important for the health of our population, I think. But we in GP are required then to understand what the kind of data security implications of that of all these kind of record sharings are. So when we give out our data to other people, other programs, private companies that are going to do work for us, like Health Tech One, it's up to individual GP practices often, or sometimes slightly larger groups like PCNs or ICBs, to make an assessment of whether it's safe for them to do that, to open up the record. So there's not much real safeguard for GP practices about how they kind of manage their data. And there are 6,500 GP practices in the country. These are not, and many of them are kind of not very tech savvy, let's be honest. So they have not very much power over this kind of situation, but a lot of responsibility. So if you are building solutions or tools for general practice, it's worth thinking a lot about kind of how you have to think about data security and data sharing and all that sort of thing, but consider where who owns the data and where it's going and how that affects the GP practice. It's really important. Cool, good. Anyone's got any questions at any point, please just throw them in the comments. If there's anything we can pick up as we go along.
There was a question from Cyberbar9.
Oh yeah, do you want to take
I think that was for me, actually. I was just like having a cheeky look over. And it's great to hear that you aren't coding, Anita. Coding isn't often the answer. Yes, I hope it isn't, because I can't do it. Rather than inventing the wheel, do you tap into the extensive human-computer interaction literature to inform your work? I'm going to be honest with you. You've capitalized human-computer interaction. I don't know whether that's a database or anything like that. In terms of informing my work, it's often through the bulletin on doctors.org.uk, the news and insights channel on my Slack channel, anything that Mark and Dom shares in our White Swan Project WhatsApp group is a mastermind group for people like us who want to change the system and upskill. I hope that kind of answers your question. But yeah, if you could tell me what this computer interaction literature, I'd love to like look into that, where there is a wealth of source of wealthy knowledge or something like that. I don't know.
Yeah, we'll Google that.
You know what that is, Dom? Even
actually, I think I've heard of it, but I honestly can't say I know what it is. So
I'm gonna have to look at it. Look it up.
Yeah, we could do it live, but let's not do it live. And Jeff, they've replied to say, research in the design and use of computer technology focused on interfaces between people and computers. It sounds really fascinating and important, and probably very useful for us to look at.
I'm going to have to look into that. Thank you for sharing that. I'm going to pass it on to all my colleagues, unless they already know it already. And then I'll say, why didn't you not share this with me?
And Jeff said, what do you think patients would think about the lack of expertise in GP practices protecting their health data? I think it's a really interesting question. I think I imagine they would be quite horrified. I think patients actually have a very little understanding of where their data is stored in the NHS and who controls it. You might remember a few years ago there was a proposal to create a central NHS health record, a single health record that would be available to anywhere, any kind of NHS service in the country for each person linked to NHS number, presumably as the unique identifier. And that's sort of happening by stealth now, but it was prevented by basically privacy concerns and poor understanding of what they were trying to do, and it would have gone horribly wrong and resulted in data leaks. But that kind of attempt failed because of a lack of understanding, I think, by patients of where their data is held now and who has access to it anyway. But I don't think they would really know. And equally, as Anita said, when people come into an appointment, and they say, I saw the consultant the other day at the hospital, or I've had this scan, and they always say, can't you see it? Isn't it on there? People are actually getting used to it now. We say no, it's not there. It's not there, and they're like, oh, okay, I'll try again next week. Patients assume that we will be able to see all of their relevant medical information, and increasingly we are able to see more of it, but I don't think they've got any idea who owns it or who's looking after that data. So what do you think patients would think about it, Jeff? What do you think, Anita? Any thoughts?
Well, it's a difficult question, and I think this people have been challenges for like the last few decades. When I was at medical school, I said that patients should have like a passport which has all their medical records in it, right? And that was easily 50 years ago, and very little has changed. I agree with you. Local care record has improved.
Yeah.
And I think in Southeast London, where I work, we can now tap into healthcare records in our local trust. So I've got King's, Guy's and St. Thomas's, I think St. George's as well. But that doesn't include the other local services within the area. So you've got maternal care, antenatal care, and they use their own system. I think it's Badgernet. You've got mental health services. Some places outside of London use Rio, and that might be familiar to some of you. Other people use EPJS as well. And then you've got things like community podiatry or community dermatology, and a lot of times patients come to me and say, oh, have you received the correspondence? The answer is no, because one, it's not integrated, and actually there is a kind of lead-in processing time where any clinic letters that get sent to the GP will then go into Docmen. So I think, Dom, you've listed one of the softwares there, Docmen. Someone from the admin team would read through it, maybe highlight areas of it that's important, try to code it, and then it gets redirected to the GP to then action. So that could easily take a week if there's a significant backlog during, bank holidays or holiday seasons. That could easily take 2 weeks. And so there is a kind of patient safety element here, because there isn't necessarily a triage system where things are marked urgent, critical, or low risk sort of thing. And that's something that we need to also be mindful of.
Yeah, totally agree. Yeah, and I think ultimately GP practices shouldn't be the ones making decisions about the data security and data sharing policies. Really, it's not really fair to them. I don't think. And you make a really good point about patients being the point of integration, Jeff. That's exactly right, isn't it? It's a shame that the systems are not built in that way, and it sounds like you're thinking about you're building something in that direction. So that's really cool. Great.
And if you want me to have a look, or Dom to have a look at the product and just kind of like have a play around, happy to have a look and give you my opinion to see whether that would integrate quite well, in primary care. And just to kind of go through some of the other additional systems. Sorry to cut you up, Dom, but things like AccuRx, some people may or may not be familiar with this. This is like an SMS system where we can send text messages to patients. Not everyone adopts it, actually. I don't know what the percentage of adoption is, something between 80 to 90%, but some surgeries still don't use it. DXS is essentially it's a software that contains local templates for referral letters and guidance. EMIS X is it's an extension of EMIS, so the EHR, where the X basically allows us to view, I kid you not, document clinic letters within EMIS. So what used to happen is you'll open EMIS and you open document. When you're on document, you can't get into the EMIS and you can't type your notes. But now with EMIS X, you can open the clinic letter and EMIS at the same time, so you can cross-reference and do referrals a bit more easily, which sounds mad, but it is what it is. If we go back to the previous slide,
yeah, of course.
Surgery Connect is a way to do telephony, essentially, where you can dial directly to patients, and your calls may or may not be recorded depending how your GP sets up. I'm getting tired. Dom, I'm going to tag you in. Do you want to explain what the other things that we have to use are?
Sure. I mean, this isn't even all of them, right? This is just the ones that I had open on Thursday when I was in practice. Actually, I didn't have DXS or Validia because I don't use those. But ERS is the electronic referral service, which many of you have probably come across. And I put integrates with the EHR up there because they often sort of do or don't really. The way ERS works is you try to create a referral in a consultation, and then it brings up basically an integrated browser window that blocks the EMIS, the health record that you're using, and then you can find the clinic that you want to refer to the patient to there and generate a referral, and then it closes that window and takes you back into EMIS where you code what you've just done. So you put in the same sort of basically the same thing into EMIS. You refer them to dermatology or whatever, you put it in there, and then close that, and then that's sort of has integrated in the sense that it's saved that you've made that referral, and it has some sort of presumably some sort of ID associated with it, and then you can generate a few other things and attach them. But while that window's open, you can't look at the record anymore. So you're if you at that point you're suddenly like, oh, did they were they on that medication, or whether was that have they got this other diagnosis? You then have to close everything and go back and start again from the beginning. So it's quite, in some ways, ERS is quite good because it lets you electronically refer to any clinic in the country.
I've got a solution for that.
Yeah,
what you do, you save your referral, you send it off, but then you go back and edit your referral and then send it off again.
I do that, but I was trying to belabor the point of how annoying it is. But that's still quite annoying, right? You still have to open the same thing and close it 3 or 4 times. But ERS is one of the better systems in some ways, because it does let you do these referrals, and it does at least integrate somewhat. Valida, I don't really know much about at all.
That's universal care record. So, for example, if there's like an advanced care planning, if there's a do not resuscitate kind of plan in place, that's supposed to be accessible by 111 paramedics and things.
Probably quite useful to log into that then, wouldn't it?
yeah, but this is the thing. There's so many tools. Some people just don't know how to use them or why they're there. They just accept that it's there in the background. But if you ask a bunch of GPs, what are all these things? They will have some vague recollection of it, but they don't actually really know what it's used for or how to use it properly. Yeah. And then I guess summary care records is, as the name suggests, a summary of like the patient notes. So acute medications, repeat medications, their problems list, perhaps, recent observations, but it is just a snapshot of everything. And then you've got NHSML, which we use for kind of intra and inter professional communication on a secure network. Then e-consultations, if the practices are running that, and the practice website. And these are, as Dom said, just a few. I would say about 60 to 70% of the things that we use.
Yeah, maybe. And the other thing is that, you know, we as the users of these systems don't have any choice about them. They're commissioned or kind of provided at some level above us. Anita's integrated that now. She's made her way in, so hopefully, you know, things will start to improve in your area. But you know, but we have no control over it. You know, if I'm working on something on my own laptop, I can decide to use Google Slides, or I can use Word, you know, or I can use anything else, you know. But I have no choice about using these things, even if they don't work for me, and they make my life harder. Make it harder for me to provide good care to my patients. I haven't really got much choice. So we put a few screenshots in because we thought it was funny. But you know, if you're working with EMIS or System 1, you probably already know all about this. But this is just the main screen of EMIS from yesterday. Again, I think I've hidden all the important bits. But it's fairly self-explanatory what's going on here. But this is the appointments book, and it's quite noisy, and there's lots of little buttons everywhere, and it's quite hard to learn how to use. And then this was my same screen. I just moved it so that you could see most of the things that I had open at once. And we thought it'd be quite fun if you could count all of the different tools which are visible on this screen, and anyone who's managed to log into the comments, if you could count them up. And
so we'll give like everyone like 30 seconds or a minute to just count up all the different softwares you think we are using on the screen alone. And if you can comment, please put it in the chat. If you can't, don't worry, we'll come to it. But I missed one out as well. I thought I had it all. And then Don was like, did you see that one there? I was like, what?
Okay, we got one. We've got a 6 from, I presume that's Mark, sneaking in. Anyone else? Go on, Joff.
I know you can text. And then who was the other person that could message? Unless they've dropped off, we've got Cyberbar9.
And Joe. Sorry, we're calling you out by name because we can't see anything else. So.
Genuinely. We're just talking to each other at this point.
Yeah, exactly. We are just talking to each other. Okay, I think 6. Thanks, Jeff.
Do the reveal, Dom.
Yeah, all right, cool. Well, so it depends. There's one. So this is definitely 7 because I'm guessing most of you missed the little green button up here in the top right. The one that's hovering next to the window kind of minimize buttons in the top right of EMIS. That is a panic alarm button. And if you press that, theoretically, everyone else's computers will throw up an alert and then people can come running in to save you. And
I would challenge and say there's an 8 though, because one of your tabs is there.
It's Teams, yeah.
It's Teams.
So I think that gets to 8 exactly.
So what we do, we have Document, we've got Teams, we've got NHSML, EMIS X, EMIS, AcuraX, that panic button that I missed, and then also Surgery Connect right at the bottom, that blue bar.
Yeah, which you can't. You can clear it completely, but you can't. And you can shrink it, but it always stays on top of whatever you're doing.
Yeah,
it's like it's so bad.
And then you don't even have DSX there, so usually that's kind of like a floating square in the corner, like a find box there, and that's what I usually have actually in the corner.
Lucky you, an extra box. This is System 1, which is the other main EMIS clinical system. Oh, sorry, that's just when it's loading. I don't use this one, so I just found a screenshot, but it's equally kind of Byzantine looking and torturous. It's a bit of a nightmare. Oh, Mark, can you pop that comment from Simon on? Brilliant. 6 at least, absolutely right. 11 is That's horrific.
That's grim. I would love to see what ones they're using just for the lols.
I'll see it. I worked at Guys and Tommies, and before they just moved to Epics, and now they've got one system for everything. But that was I think you had to have about 5 or 6 open for a ward round on the tiny little computer on wheels screen. It was just awful. But 11 is a new high. I think that's incredible.
That's peak, yeah.
Right, we're nearly done with the slides and stuff. But just to mention, I think we talked about this briefly already, but about the local care record and the shared care records and how they're very, very useful, because we can see information from the hospital. And actually I can go in now and for Guys and Tommies and Kings, I work in South London, I can see kind of all the clinic letters that the hospital system's holding, which may or may not have been sent to us, or maybe lost somewhere in that workflow that Anita was talking about when they come in and go through DocMan. And can see investigations that they've done, so any blood tests that they've done, any radiology reports. Sometimes you can click a button and maybe see the scan, but it never actually loads the images, which is quite sad. They didn't let us see them in GP.
GPs are not supposed to review scans anymore, are they?
Yeah. And you can sometimes see appointments on there as well. So actually I find myself being a medical secretary quite frequently, and patients are like, oh, have I got an appointment? And I open that up and I go and I find it and go, yes, you've got a haematology appointment next week and it's on this floor. And that's, I don't mind doing that, and that's what the patient needed at that time, but it's not a very good use of my time, to be perfectly honest, and that it's not a very good use of their 10 minutes either. And you can't copy and paste out of these systems either. So it is a bit of a nightmare. We've got some really good questions coming in, which is awesome. So we'll pick those up in a sec. I mean, we could talk a bit about what would help. I think we've kind of sprinkled that in as we go. But do you want to expand on it a bit, or should we just drop into questions, Anita?
I'm happy to drop into questions. I feel like we've basically, as you said, sprinkled it all across our presentation about the bugbears and the pain points that we have. And I think it's actually shared within the community and the people attending this kind of meeting. I'd love to just get into more of a discussion, see if there's anything that we can do to help, if there's any collaboration that we can get involved in. We've got some questions coming through. So
great, let's take some questions. I'll pop this slide up because it's got an email address on it. As Anita says, be very happy to speak to anyone afterwards as well.
Yes, so Cyberbun asks, what's your opinion of total digital triage with parity access, which is resulting in more difficulty for patients to access GP and making more failure demand for staff and GPs too?
Yeah, we can both answer it. I mean, that's a very big question. And one of the GP practices that I'm working at are going for total triage. I'm not sure I agree with the model, but one depends on the population needs, how the practice works most efficiently. And I think in the ideal world, it's a bit of both. It's really difficult, isn't it? Because you have to also think about, if we're talking about digital total triage, now that's another ball game as well, about digital inclusion or exclusion, really, access, time. I think it's very, very difficult. And actually, most people would prefer the old school, get on the phone and make the call, talk to someone human. I don't know, what are your thoughts, Dom?
Yeah, I definitely agree that it opens problems for patients who have full digital literacy, in particular, digital triage. I think that there are a lot of our patients who would prefer to get on the phone, but that is that's sort of impossible to do. But I mean, maybe that shouldn't be a limiting factor. But actually, a lot of patients don't want to sit on hold for half an hour on the phone, and a lot of patients have jobs, and historically people would just have an open clinic, and then they would come and fill the waiting room, and then they would get seen in order of arrival, and then once the clinic was the room was empty, everyone could go home. And that system also, I don't think would work in the modern age, because most people can't sit in a clinic room, waiting room.
I guess the good thing about, sorry to kind of interrupt, I was just thinking about it. The good thing about digital triage is that people can put in their queries at any time. And then when the clinician gets around to it, they can signpost appropriately and prioritize. But I feel that there should be appointments that are allocated to digital triage. Yeah. Some that are on the same day, for example, because we do need to make space and time for those who really, really need it but can't access digital for whatever reason.
We recently moved to a total digital triage in the surgery that I work in, And I have to say it's actually been quite successful, I think. I'm not super close to the full implementation because but I've definitely noticed that from doing clinics before and after the change, that the patients booked in with me are generally much more appropriate presentations to be seeing a GP. So I've had far fewer appointments to do extremely small kind of administrative things like issue a medication, and far more that have been kind of new presentations of medical problems or kind of complex existing conditions. So it seems like it can work in certain areas, in certain ways, really, really well, and it's definitely improved that. I can't speak kind of globally to whether it's how it will be or how it will be in a few months' time when things are bedded in properly. But if it allows the practice to have more time, less time spent doing certain types of admin and more time to be kind of present in reception and welcome patients who aren't able to use the computer system, and help them, guide them through the system to get them an appointment when they need it, and that's only for the better. But I guess it remains to be seen whether that's how things will pan out.
Yeah, I know some surgeries are using things like chatbots to signpost one-to-one, make sure it's nothing serious, but then signposting patients to local services. So, for example, whether it's more appropriate for pharmacy as part of like Pharmacy First or Pharmacy First Plus scheme, where actually pharmacists can prescribe antibiotics or treatment for, I think, 6 or 7 kind of conditions, isn't it?
Yeah.
And that's quite useful because sometimes, a patient comes in, they're like, oh, I've got a urine infection. I'm like, okay, someone else might be struggling out there with something else, significantly more serious, but I'm happy to still consult them. It's just using, appropriate use of clinicians' time. So let's have a look at some of the questions. Cyberbarn 9, we've hopefully addressed your question. Simon had a comment in regards to the different the 11 apps that his colleague had to use. He needed 2 monitors, and I think more time. Most GP surgeries have 2 monitors now, anyway, isn't it?
Yeah.
And then Simon had a follow-up question. He says, "I work with System 1, doing config and template management. Do the practices you work with get your templates and set for EMIS or System 1 from one of your exemplar providers, e.g. Ardens?"
Yeah, we get ours from Ardens.
Same.
Yeah, they're very good. But there are hundreds of them. You look through the amount of stuff that Ardens provides, it's extraordinary. And as Anita says, I've not been able to make the time to go through and look to see whether I'm using enough of these things.
Or using them appropriately, because at the moment I'm going through the DCB or hazard logs, so basically making sure that they're fit for use and clinically safe, and going through all the potential things that could go wrong that might affect patient safety. And I think some of the things is that sometimes things can be miscoded, or incomplete data still gets interpreted as data and it's not fed into the algorithm or the calculation, and there's still things that can be improved. Or if there's an Ardens template update, whether the practice is informed, and then does the practice inform the clinicians who are using the templates, for example. I think there's a lot. I think it's just raising more awareness to clinicians in terms of limitations of digital and what we need to stay on top of.
I hope that answers your question, Simon. Oh, great, excellent. Got some more good ones. Grant, did you want to pick anything out, or shall I just jump in?
Yeah. I had one for myself, which I just put into the chat. But before we to that, Jeff makes a really interesting point about the opaqueness, about the multi-channels, about so many different ways of contacting and then being not clear where they are, and in terms of clear singular understandings and feedback. I don't know what your views are about this multi-channel problem. We've got an app for this and app for that, sometimes from the perspective of the patient, let alone from yourselves. Do you have any thoughts about how that could be addressed?
I think the NHS app is doing really good work, isn't it? Sorry, Anita, you go.
I was literally going to say that. I want the NHS app to be the digital front door. I feel like the first thing that most people should do is go through that app, type in a question or whatever, and then it signposts you appropriately. I would love for it to actually have a voice recognition. or something like that. Because if people aren't able to use their phones or whatever, they can speak into their phone. It will pick that up and signpost appropriately. But I think we just need one app. I know that, I don't know whether you use MyChart or you're aware of MyChart. So that's with Guys in St. Thomas's. If you have an appointment over there, you get email notifications. They ask you to download the app, and it's MyChart plus NHS app. And it's just app overload. And you can see why patients are a bit reluctant to keep one engaged or download all these things. It's just more and more, isn't it?
Absolutely, yeah. I mean, we use a lot of text messages in GP, as I'm sure you all know. You probably all get text messages from your GP through Accurex, which is a great tool for us to send messages to patients. It has been amazing, and in the pandemic it was indispensable. But we were having a conversation recently about text message versus WhatsApp as a kind of way to reach patients, and that most patients actually spend a lot more of their time in things like WhatsApp. They're more reliable. SMSs are really unreliable and quite an insecure form of communication. And anyone can spoof them as well. So you don't really know where those text messages come from. So I think that's definitely something that will hopefully change over the next few years. Again, NHS app has a notification system now. So if patients are actually on it, then they kind of will get messages through that. So hopefully that golden world where everyone uses the NHS app for everything is
please. I want it to be as I don't know, as desirable as WhatsApp.
Yeah,
that's one of those ones that you have to download and just have it on your phone.
Yeah, but there will always be that subset of patients, I don't know what percentage of patients who aren't able to use it, or who aren't almost aren't willing to engage with it to some extent. But there will be people who just aren't able to use it. And voice recognition might help some, but there will be people for whom even that won't be enough.
And there's things like linked accounts. I don't know whether you're aware of that. On the NHS app, you can link accounts as well and have proxy access. So I think they are trying to minimize digital exclusion as far as possible.
Yeah, and that does sound like it's really, really good work. But yeah, there will always be those people who don't have a carer who's kind of willing to take on that responsibility as well. So I think it's really, really difficult, because it's fun and it's amazing to imagine these kind of these worlds where everything's connected and it all works perfectly. But it's always through a screen.
Yeah.
So yeah. I don't have a solution to that problem apart from funding basically practices or the system in general to have people who are able to interact with other people and make sure that these holes are covered. And it will be expensive. It will cost more to cover that final 5-10% than it costs for for a huge proportion of other people. But that's the reality of providing universal care to all.
Absolutely.
I'm getting on my hobby horse now. Climb off again.
Yeah.
Cool.
I mean, Jeff also makes a very good point about healthcare is more than just either primary care or secondary care in the context of the NHS, but it's also potentially in the private sector as well. And at the moment, the data is locked away, dental and so forth, is locked away in so many silos, and it would be wonderful that those are de-siloed so that in potential everything could be shared with everybody, potentially with patient consent as appropriate, but particularly that the patient can have access to those. There is a question from Oxford Clinical Haematology, which is me. Earlier you mentioned dangerously unusable software with these systems. Do you have examples where they resulted in real harm? And as this harm in terms of bad software being serviced nationally, so we have an idea about how much harm this like we do for drugs?
Yeah. That's a really good question, isn't it? I think there isn't really a system for reporting bad software, is there? Like a yellow card for a drug reaction. I don't think we have that for these systems.
I'm not aware.
No, I don't think it is being surfaced nationally. If I got a good example, I can't think of a recent one from GP. I mean, I think it's actually this like unknown unknowns and sort of Donald Rumsfeld thing. I think I'm certain that I miss things in clinical practice because it's hard to click around the system and find everything. And I can't think of a good example off the top of my head right now from recent GP, but I can think back to when I was working in A&E, and again with bad systems, and I accidentally anticoagulated a man with treatment dose anticoagulation for a presumed blood clot, but he was already on warfarin, so he was already anticoagulated. So that was an extremely bad thing to do. He could easily have had a catastrophic, bleed or a stroke or something. Unfortunately, he was fine. But that happened because the records access wasn't working, and so I couldn't see that he was on those things. And he was he wasn't able to tell me. And possibly if I'd been less busy and other things, I might not have made that mistake. But if the systems had been working well, then I also wouldn't have done it. Just before I move on, Jeff wanted to. No, it's gone actually. Oh, you mentioned about the data being locked away. I think you're talking about this with the passport idea, but it really the record should in some way belong to the patient. The patient should have control over who gets to see it as well. So if I want to see that person's record in clinic, the patient can provide me access, and then I should be able to see everything.
I mean, that functionality actually exists. Is a company I've worked with in the past called Patient Knows Best, which is precisely that. It's patient controlled healthcare record. I mean, they're not the only one working that space, but I know they're a big player nationally, so that the patient always has their own record, and they kind of make their money by facilitating sharing that record with trusts. We had a deployment at one point in clinical hematology before Central Digital nixed it, because they're going to have their own patient portal, and it was actually fabulous. That the patient could actually see all their blood results, all their labs, and then when it came with a particular issue, we could then open up their record to. We had a case with a dermatologist that there's something weird that was going on with one of our patients. Open it up, got a thing. So this kind of thing with a patient-centered record does exist, and it does work very well. And it's somewhat of a shame that model is more prevalent, and perhaps that the NHS should, in a sense, take on the role of providing a patient-centric thing for the patient's own. But that's another story.
I think the NHS really has the clout to do it. I think and it could do it. It does have the clout. We're not like in America where we've got millions of different hospitals that are totally independent. Maybe that's me being.
Yes and no. The problem about the NHS is that it's mostly brand and coordination, because each of the care, in GP land, each of you is its own company, so its own silo, and each of the trusts are all their own independent legal. Sure, the central government could mandate it and we would make it happen, but at the moment, in terms of provision, we as NHS were fragmented.
I think just to kind of bring us back to the questions, because I'm very mindful of time. Simon had a question, and they asked, do you get to build or create or modify templates to suit local practice? I believe we can build our own templates and we can create them, but not necessarily modify them, because they've got their own inbuilt algorithms and things like that. Because if we modified, how would that? What I don't know.
You modify it, but the question then is that you're building a medical device at that point sometimes. So,
so
it's also, is it safe? So if I go and fiddle with the key risk template to customize it for myself, for some reason, at that point I've built a clinical calculator, and that's okay for my own personal use. I can stand up in court and defend that. But yeah, you're running risks, right? You could make it. It's easy to make a mistake with those tools as well, which it's a whole other kettle of fish. How much power do we give people to dig their own holes?
I do write my own templates, but more for AccuRx, which is the messaging system, because it's very the same themes that come up. So I don't know whether the audience are aware of the Synovus issue, where basically there was a cyber attack and a big issue with bloods and things, and we had to send mass text messages, and it got to the point where it got so repetitive. I just created templates just to explain the situation, kept sending out, when it's ready we'll do all of this, that, the other. Or for local mental health services, because there's like a significant prevalence of mental health, so I create my own templates. But I'm sure our colleagues have also done similar things, and I think it would be good to share the templates on some sort of platform. We pick and choose what we think is useful for us, perhaps.
You can share in AccuRx certainly through the surgery, but I think through the PCN they can do like structured sharing now as well. But share the templates that you use, please. Save me some time. Anytime.
Cool. Well, if there's not any, so I should say that Cyberbar 9 makes the comment that Phil will be in his book Fix IT is call for a national register for when digital and IT goes wrong, like they do with drugs. I think on that he's entirely correct.
Cool. Maybe we should set it up and then we
he can set it up, and then we'll use it.
It's just a bulletin board, really. So
That's the thought.
Yeah.
Well, if there's no further questions, as far as I can see, there's any further questions. It's probably, unless there's other comments to be made, I think it's probably nice to kind of draw this very interesting discussion and exploration of GP and the GP digital world and its frustrations. It's interesting for somebody who comes from hospital and working with those systems that that's pretty much the same too.
We're trying. I think that's the most important thing. We're trying, and let's communicate more, share more, and troubleshoot more. I'm happy to just take some time.
Yeah, likewise. Anyone who's been here, on this thread, if they want to reach out and chat about any of this stuff, I'd be really happy to. And Anita would as well. We could get in the same room.
Yeah, I mean, and those in the audience, please do go to the Let's Do Digital website, and there's some contact forms and email addresses such as there. Thank you, Mark, in the background for putting that up. Please do feel free to email us with any further questions, queries, comments, particularly if you want to raise them with Dom and Anita about this talk, but anything more generally, and we'll feed that into the mix for future sessions. So without further ado, thank you very much, Dom and Anita, for your time, and thank you, audience, for being here and engaging, and we'll catch you next time.